Listen, I realize that you cannot see this board very well, and I apologize. What we're going to go over today is pathology of the esophagus. Okay? So, I want to try to fit this in 10 minutes. I really don't know if I will, but pathology of the esophagus. The most, one of the more high yield ones, and I like to start with it because it starts with A, okay, it's achalasia. Okay? So, to start with achalasia, let's talk about the etiology. So who gets achalasia? Oftentimes, this is a non-smoker person, okay? Oftentimes, it's idiopathic. This person is a non-smoker. They're younger. They can be younger. They can be non-smoker. They can present with Chagas, right? So how does Chagas present? Chagas presents oftentimes initially puffiness of the eyes, and they can have megaesophagus, megacolon, right? But that's not that important. Some of the causes of achalasia, the most common ones, this thing is idiopathic, right? We are idiots. We don't know what causes it. This is idiopathic. The other thing that can cause it is T. cruzi. Diabetes mellitus patients can get this. But really what it is anything that increases the tonicity of the lower esophageal sphincter, of the LES, anything that increases the tonicity and the pressure of the LES is going to cause achalasia. That's what achalasia is. Let's review your GI histology real quick. So say this is the lumen of the esophagus, or the lumen of the stomach, or whatever. First layer right here is the mucosal layer. The mucosal layer is just an area of mucosa. It's not really cellular or anything like that. And then we have the submucosal layer. Okay, submucosal layer. There can be nerves and things like that in there, and then right here we have the muscularis propria. Okay, so the muscularis propria is what has the myenteric ganglion, right? So the myenteric, and then we have the serous layer. So the myenteric ganglion is what is lost with achalasia, okay? We have a loss of myenteric ganglion. And when we have a loss of myenteric ganglion, it causes the LES to increase, okay? The pressure and the tonicity of the LES to increase. And that's basically what achalasia is and how it presents, okay? And those are some of the causes of it. These patients are going to present with, they're going to have dysphagia. They can have regurg. They can have dysphagia, regurg, aspirations. Okay? So that's how this patient presents as far as symptoms. So the pathology of it is this loss of the myenteric ganglion. Some of the symptoms, to diagnose this, we can send a scope down there, and in the scope you can actually visualize the esophagus tightening up and getting closer, but the best way to look at this is through a barium swallow, right? And we do the x-ray. So if we do a barium swallow, how does it present? I mean, very obvious. What you get is this dilation of the esophagus, and then right where the LES is, you get, it sucks in because of the increased tonicity. So they call it this bird beak thing. But what it is, basically, is this dilation right here, of the esophagus, and then that increased tonicity, and it's not allowing any of your food to come down, okay? So, that's pretty much how it presents. A lot of times to treat this, what they'll do is they just give these Botox injections, alright? Right into the muscle. But you have to do this, you know, this isn't a one-time treatment thing. You have to keep doing it, so they can also just do a myotomy, okay? So they can do a myotomy of the LES, especially if this is persistent and chronic. You'll do a myotomy. Another high-yield fact about this achalasia is that achalasia, long-term achalasia, leads to squamous cell carcinoma. Anything that leads to a cancer, like achalasia and Plummer-Vinson syndrome, which we're going to talk about, these can lead to squamous cell carcinoma. That's high yield, okay? Let's talk about stenosis and webs and rings, okay? What you need to know about stenosis and webs and rings is oftentimes with stenosis, webs, and rings, these are post-inflammation. Post-inflammation, okay? Post-inflammation or infection or something, and it causes your cells to want to try to recover from that, and so it can cause a fibrosis or a scarring or a hardness, okay? So webs and rings, stenosis, all of that, okay? So fibrosis and scarring. There's two things that we want to talk about this, okay? So that are high yield. Plummer-Vinson syndrome, okay? So Plummer-Vinson. Okay. So with Plummer-Vinson syndrome, for some reason the test makers, they like this And it really it's not that big of a deal, but it's just a little tiny fact. But what happens is with Plummer-Vincent syndrome is you get it's three important things about it. Okay, the first thing that's important about this is that what causes this most is an iron deficiency anemia. Okay? Iron deficiency anemia. Another important thing about this is that these patients, they get these webs and these rings. Okay, webs, rings. One of the main rings is this the Schlotsky's ring, right? Yeah, Schotsky. Schotsky's ring. Okay. So the main thing is to get these rings, okay? And these rings, they're like this. They basically invade the mucosa, and it's this fibrous tissue of the mucosa, and it causes this full ring around the esophagus. Okay. And so since it's causing those webs and those rings, they can get dysphagia. The third thing, though, is you get glossitis. Okay. So these patients will present with a red, swollen, painful tongue. All right. So red, swollen, painful tongue. It can be glossitis. And then that's basically how these patients are going to present. Okay, so this isn't that big of a deal, but for some reason they do sometimes write tests questions on it. Okay, I said before that this one also lead to squamous cell carcinoma, just like achalasia does. All right, done. Schotsky's ring, Plummer-Vincent syndrome. That's what you need to remember about that. All right, let's move on. Diverticulous. Diverticulous. So the high-yield diverticulum or diverticulus in the esophagus is Zenker's. But remember, Zenker's is also called pharyngeal, okay? And that's because it happens in the pharynx, right? It happens just above the upper esophageal sphincter. So Zenker's or pharyngeal, okay? So above the upper esophageal sphincter. All right? What it does is it develops like this. Okay, so here's the oral cavity, and then it starts to head down into the pharynx, and then it develops this pouch, right? This diverticulum right here, and then here's the upper esophageal sphincter. Okay, and so it develops this pouch, and then so the food then not only goes this way, but it goes this way as well. So then we get food in here, and it causes irritation, and even this can lead to squamous cell carcinoma. Okay, squamous cell carcinoma. And okay, so yes, okay, so there we go. That's what we have. Darn it, my battery's running out. I'll try to finish this topic, and then we'll make another one for the next one. Okay. So with Zenker's, you get regurg. The food can come up, but the thing is, this food inside here rots, so they have severe halitosis. Okay. So basically, what you need to do is they need to go in and resect this. You can actually see this on a barium study. You're not going to blind scope this guy, okay? Because you could send it right through the diverticulum part and just puncture that area. So we're not going to blind scope this guy. What we want to do is a barium, and what it looks like is like here's the oral cavity, and then it kind of looks like it's like this outpouching full of barium, and then it like skips an area, and then this part has barium as well. Okay, so that's what it kind of looks like on for your barium study. Another thing, high yield thing to know about this is that they call this a cricopharyngeal motor dysfunction. So cricopharyngeal motor dysfunction. Okay, because what it is you basically have problems with the motility. Okay, this is usually spasms or outpouching, and it's a problem of the motility. What causes it is you get diminished relaxation of the pharyngeal muscle. Okay, so diminished. I'm worried about my battery. Diminished relaxation of the pharyngeal muscle. Okay, so that's Zenker's. Zenker's is the high yield one. You can also have a traction diverticulum, and an epi. above the diaphragm, so epiphrenic. Okay, so this one's going to be right at the LES, just above the diaphragm, and this one's going to be mid-esophagus. Okay, so all of these, the Zennikers, or the pharyngeal retraction, or the epiphrenic, they all present with regurgitation, they all have mass formations. Really quickly, another diverticulum that's very common, without talking about diverticulitis and diverticulosis, is Meckel's diverticulum. So what Meckel's diverticulum is, this one happens in the small intestines, right? It's the rule of 2, so it's 2 inches long, it's 2 feet above ileocecal valve, and so this is actually pretty high up, close to the esophagus. Okay, I mean not the esophagus. All right, closer to the duodenum than you think. But Meckel's diverticulum is when the vitelline vein or the vitelline duct has a failure to close or to shut down. And so these patients will present. They can present with feces that are coming out of the umbilicus. So that's kind of gross. The other thing is that's a true diverticulum. So that goes through all 3 layers. The mucosa, the submucosa, and the muscularis propria, okay, of the bowel wall. So failure of the vitelline duct.